my name is Rachel McConnell. I'm a physiotherapist that works in the Motor and Neuron Disease Clinic here in Dublin. And I just want to say thanks for having me here today. This work is a small part of my master's research thesis. And this research has been completed with Dr. Deirdre Murray, Professor Orla Hardiman, and Dr. Dara Meldrum. So the title of the presentation today is Mechanical Insufflation, Exsufflation, and Breath Stacking, the Patient's Experience. So I'll just refer to mechanical insufflation, exsufflation as cough assist from now on, just to make it a little bit easier for myself. So just to give you a little bit of a background, as you know, respiratory symptoms and respiratory complications are the #1 cause of death in ALS. And this is because the motor neurons become involved, respiratory muscles become weak, and respiratory infections can become frequent, and the weakness in the respiratory muscles can impact the strength of the participant's cough. So with these chest infections and a reduction in their cough strength, it can impair their ability to clear these secretions. And quite commonly in the literature, there are 2 values of peak cough flow, which is regularly used to measure cough strength, are mentioned. So a peak cough flow of less than or equal to 270 litres per minute is associated with respiratory complications. And a peak cough flow of less than or equal to 160 litres per minute is called the cough critical threshold. And this is a value, if you're below this value, participants or patients are unable to clear secretions effectively. So this is where cough assist and breath stacking come into play. The breath stacking device is made of a resuscitator bag and a one-way valve. And what it does is it helps to inflate the lungs to a larger volume than they would naturally themselves by stacking breaths one after the other. So they get this large inhalation. It helps to mobilize their rib cage, mobilize secretions, reverse atelectasis, and it can improve their cough strength. So breath stacking has been shown to improve cough strength up to 30 minutes after using it. The second device is mechanical insufflation, exsufflation. So this is an electronic device that uses a positive pressure and a negative pressure. So the positive pressure, similar to the breath stacking, helps to get that large inhalation volume, and it's followed then by an exsufflation phase, which is a negative pressure, which helps to increase the peak cough flow and the expiratory pressure gradient between the alveoli and the mouth. So both these methods have been researched to some extent in motor neuron disease, or ALS, and they both have been shown to improve cough strength greater than a normal cough in motor neuron disease patients. One study looked at 7 different cough augmentation devices, including cough assist and breath stacking, and cough assist was considered the most effective in increasing the cough strength, followed by breath stacking. And cough assist can increase a cough strength greater than that critical threshold of 160 litres per minute. There was a Cochrane review completed in 2013, and there was insufficient data to support or not support the use of cough assist in neuromuscular disease patients because of insufficient data. Since that time, there has been one randomized control trial that looked at a group of patients prescribed cough assist and one group prescribed breath stacking. Unfortunately, there was no statistical differences between the 2 groups, but you can see that more studies are emerging, higher quality studies are emerging now with cough assist and breath stacking. So looking at, obviously this is all about the patient's experience with cough assist and breath stacking. So to date, there is limited published evidence on the self-reported benefits, the experience and usability of cough assist and breath stacking in motor neuron disease patients. 2 areas that I have come across include quality of life and self-comfort and self-efficacy. That one randomized control trial that I mentioned earlier, looked at quality of life between the breath stacking group and the cough assist group. And there was no difference between the two groups. Although the quality of life didn't increase, it also did not increase with the addition of the cough assist or the breath stacking devices. When looking at self-reported efficacy and comfort, the cough assist was compared to suctioning in ventilated patients, and the cough assist self-reported by the patient was more comfortable and more effective than suctioning alone. And in that study that I discussed earlier about the 7 cough augmentation devices, cough assist was reported to be the most effective, but the second most comfortable device to use, and breath stacking was the 3rd most comfortable device to use. And the comfort was rated on a 10-point visual analog scale. So there was limited published evidence. I wanted to look a little bit deeper into the patient's experience and the usability of cough assist and breath stacking. So that's where my aims for my project started. So the first aim was to assess cough assist and breath stacking usability. The second aim was to measure self-reported adherence with cough assist and breath stacking. And the third aim was to evaluate the self-reported effect of cough assist and breath stacking on cough strength and speech volume. And finally, to evaluate the self-reported cough strength during a chest infection. So this was a cross-sectional study that took place alongside a larger prospective study. A questionnaire was developed, so it was a quantitative study, and it was a 13-item self-administered questionnaire that I developed because there was no methods out there really to look at the usability and experience in cough assist and breath stacking. So the questionnaire, as I said, was developed by myself, 13 items. 10 of the items were Likert scale statements with corresponding Likert scales from 1 to 5, from strongly disagree to strongly agree. And a few of the questions just were multiple choice in terms of did they use it with a carer or not, and there was a final section which was looking at the comments for any feedback. The first 3 questionnaires were piloted, and I'll move on to the results now. So there was 14 participants that were prescribed a device. So what happened is they were prescribed a device, normal clinical practice in our motor neuron disease clinic. Then the next time they came back to clinic, I administered the questionnaire, gave them the questionnaire, and they completed it on their own or with a family member or carer. So there was 14 participants, 8 were male and 6 were female. 10 had spinal onset M&D, 4 had bulbar, and 5 cough assist devices were prescribed, and 9 breath stacking devices. There was the time from being prescribed the device to completing the questionnaire was just over 2 months on average, and the time from diagnosis to completing the questionnaire was about 11 months. You can see here, out of the 14 participants, only 1 participant did not use their device, and that was a breath stacking device. So you can see that there is a very high adherence rate with cough assist and breath stacking in this population. One of the questions I was really interested to find, were the devices comfortable? Because in a clinical practice, you give them the devices, they go off and they're using the devices with their carer family. And it's very unusual, that we look in depth at, say, comfort and things like that. So one of the statements was, I think the device was comfortable to use. You can see here from the bar graph, it ranges from disagree, neutral to agree, that there's a high level of agreement to that statement. And then I stratified the results into cough assist and breath stacking. And you can see that the breath stacking was reported to be more comfortable in the breath stacking group compared to those in the cough assist group. So this, I suppose, is just showing us that both devices were considered to be comfortable, but more so in the breath stacking group. Then moving on to the self-reported effect of cough strength. The statement was the device made my cough stronger. You can see here that there was a high level of agreement to this statement, and 100% of the participants who used the cough assist agreed with this statement. So concluding that patients do think that it does increase their cough strength, but more so with the participants who were prescribed cough assist. Then moving on to speech volume, the graph on the left is the combined responses, and you can see that there's a large neutral response to the statement, the device made my speech louder. And when that is stratified into breath stacking and cough assist, you can see that there was a higher level of agreement in the cough assist group. So mixed results really with speech volume, but more so, more agreement in the cough assist patients. I also want to look at, did cough assist and breath stacking increase self-reported cough strength during a chest infection? Unfortunately, well, not unfortunately, it was a good thing that only one person reported a chest infection, and that was they were prescribed cough assist, and they did report that the cough assist increased their cough strength during a chest infection. So that's just, okay, so it's a brief summary of some of the results from this research, and some of the limitations that I would like to highlight are the question methodology. So it was a methodology, a questionnaire that was developed that had no historical or comparative data. So we can't compare to any other research, even though the research is quite limited. The Likert scales, they were on a 5-point scale, so they're quite one-dimensional, giving you only an option of 1 to 5. And the timing of the questionnaire was completed on average 2 months after prescribing the cough assist or breath stacking. So you can see that we're only getting an idea of roughly around 2 months. Things like adherence could possibly change over a much longer period. And also the statistical challenges that are faced with a small population size of 14 participants. So future research should really focus on a larger sample size, looking at the impact of cough assist and breath stacking on the long-term experience and usability, and also caregiver burden in the form of both quantitative and qualitative studies. In addition, electronic adherence monitoring of cough assist and breath stacking would give more accurate adherence rates. So in conclusion, this is the first study to systematically evaluate ALS participant experience in cough assist and breath stacking. Overall, patients had a positive experience, and I think that all factors such as device usability, self-reported effects should be considered prior to prescribing cough assist and breath stacking in this population. So just to summarize, patients had a positive experience with cough assist and breath stacking. There was a high adherence rate, and it was user-friendly. Cough assist and breath stacking increased self-reported cough strength, and the self-reported cough strength during a chest infection is undetermined due to a lack of data. So thank you very much.
Thank you, Rachel. Okay, do we have questions? Can't see any hands going up. Anywhere? Yeah, we've got one in the middle.
Hi, I'm Amy Parks. I'm a physio at Preston M&D Care Centre. I'm just interested if you have in any previous work or within the context of this looked at kind of rating scales, so their perception of their secretion burden, you know, what difficulties were these 14 patients experiencing to get those kind of, you know, what subjective markers would you use or objective markers to measure their secretion burden basically to then deliver that treatment plan? And did it have an effect on those symptoms?
So another part of my research master's was looking at the prescription process of cough assist and breath stacking, and one section was looking at the subjective symptoms. I haven't come across any rating scales myself, but I just came up with a selection of subjective symptoms. So at the time of prescription, those subjective symptoms were taken into account, and the most common symptom was an inability to clear those secretions and kind of that burden of secretions is the most commonly reported subjective symptom when getting cough-assisted breath-taking.
Thank you. Any others? No, last chance, going once. I'll just say I'm surprised how many physios like me and you there are in this room. It's wonderful. Really good. Thank you, Rachel, once again.